Hi, I'm going to talk to you today about two of the exemplars in metabolism, and they're exemplars 12D, liver disease, and 12E, thyroid disease. I'm not going to read you the objectives, but just understand that you're trying to relate this to metabolism. So when we're talking about pathophysiology and etiology, we're looking at a few things. We're looking at the metabolic functions of the liver that are lost with fibrous scar tissue. One of those could be cirrhosis, and we'll talk about that in a minute. And what happens is you get a disruption in the blood and bile flow within the lobules or the lobes of the liver, and that can lead to portal hypertension. So there are alcoholic cirrhosis is one of the big causes, and that is the end result of alcoholic liver disease. Its development is directly related to alcohol consumption, specifically the total amount of alcohol consumed, the number of years of excessive alcohol consumption, and blood alcohol levels. Women develop cirrhosis at lower overall levels of alcohol use than men. The reason may be less effective metabolism of alcohol in women, resulting in higher blood alcohol levels. Alcohol cirrhosis causes metabolic changes in the liver. Triglyceride and fatty acid synthesis increases, and a decrease in the formation and release of lipoprotein leads to fatty infiltration of hepatocytes. At this stage, abstinence from alcohol can allow the liver to heal. However, with continued alcohol abuse, the disease continues to progress. Inflammatory cells infiltrate the liver, and we call that sometimes alcoholic hepatitis, causing necrosis, fibrosis, and destruction of functional liver tissue. In the final stage of alcoholic cirrhosis, regenerative nodules form, and the liver shrinks and develops a nodular appearance. Malnutrition commonly accompanies alcoholic cirrhosis. There's also biliary cirrhosis, which is caused when the bile duct is obstructed, usually from a kidney stone, a gallstone, not a kidney stone, a gallstone, and the bile is obstructed within the liver or the biliary system. The retained bile damages and destroys liver cells close to the interlobular bile ducts. This leads to inflammation, fibrosis, and formation of regenerative nodules. There is also post-hepatic cirrhosis, so advanced progressive liver disease results from chronic hepatitis B or C or from an unknown cause, is called post-hepatic or post-necrotic cirrhosis. Chronic viral hepatitis appears to be the leading cause of post-hepatic cirrhosis in the U.S. In patients with this type of cirrhosis, the liver is shrunken and nodular with fibrosis and excessive or extensive loss of liver cells. Risk factors and prevention, high-risk behaviors we talked about a few minutes ago, excessive alcohol use, IV drug use, and blood-borne hepatitis, like hepatitis B and C. To help prevent it, we want to make sure that they're seeing their healthcare provider regularly, maintain a healthy weight, avoid alcohol and illegal drugs, and take all medications as prescribed. Enlarged clinical manifestation include enlarged tender liver, dull aching pain in the right upper quadrant. They may have weight loss, they may have weakness, they may have anorexia, meaning not how we think about it when we think about a teenage problem, more just that they just don't have an appetite, they just don't want to eat. Diarrhea or constipation, portal hypertension, includes bleeding, ascites, gynecomastia, jaundice, neurological changes, peripheral edema, anemia, low white blood cell count, and low platelet count. Multisystem effects of cirrhosis, these are pretty broad, or there's a lot of effects. I'm not going to read you all of these effects, but you can see that it impacts every system. From a neurological perspective, that portal system portal hypertension, can lead to an encephalopathy or an inflammation of the brain. And that leads to agitation, which then progresses to lethargy, stupor, and coma. There's sensory disturbances, and they can have um, uh, asterexias, which is called liver flap. Um, we talked already endocrine a little bit. Respiratory, this has to do with I guess I always call it your anatomical real estate. Because if your abdomen is sore, or it's painful to touch, then you're not going to take deep breaths because of where your diaphragm sits. So then you're going to start taking littler breaths, and as things worsen, you're going to get worsening dyspnea. Um, GI wise, they can start to form esophageal varices, and we'll talk about those in a few minutes. Abdominal pain, I already talked about. Everything else. Ascites is another problem they'll get, which they get that enlarged abdomen that becomes has peritoneal fluid in it. They may develop GI bleeding, and their skin will be jaundice, and their sclera will be jaundice. They get a lot of other symptoms as well, but I'll let you look those up. Other clinical manifestations, or to continue with those, portal hypertension. So what happens is you get a shunting of the blood because the blood isn't able to circulate through the liver as it normally would. So you start seeing the blood shunt away from the portal veins, and so you get an increased pressure in the vessels. You'll get an enlarged spleen. You'll get ascites. Esophageal varices is another big problem. What esophageal varices are they're almost like a hemorrhoid, but they're in the esophagus. So they're a large vascular pack that starts to build in the esophagus, and they're not sure if it's generally related to alcoholism, but alcoholism in relation to the portal hypertension. So you get an increased acidity in here in your esophagus, and the varices form, as well as like just the consumption of the alcohol. Hepatic encephalopathy, which is a cerebral edema or an inflammation of the brain, and that can be due to an increased ammonia. Again, with the portal hypertension, you're not excreting your ammonia as you normally would. Hepatorenal syndrome is sodium retention, oliguria, hypotension, and due to an imbalanced blood flow, and they can develop spontaneous bacterial peritonitis. Collaboration, you want to address the physiological, psychosocial, and spiritual needs of the patient. They're going to do liver function tests, CBC, coagulation studies, electrolytes, bilirubin, albumin, ammonia, glucose, cholesterol, abdominal ultrasound, EGD, and liver biopsy. Avoid hepatotoxic meds, alcohol, and medications that are metabolized by the liver. Remember, one of the most well-known over-the-counter hepatotoxic medications is acetaminophen or Tylenol. Now, they may end up needing a liver transplant, and that takes us back to the physiologic and psychosocial as well as spiritual needs, because if they end up needing a liver transplant, having a transplant at all is expensive because of the medications that they need to be on for the rest of their life. If alcoholism is what has destroyed their liver, then you're looking at big other psychosocial problems, such as they have to commit to not drink, or they have to be dry for a number of months or years before they would be considered for a liver transplant. And that all depends on what your organ donation requirements are within your state. Pharmacological therapy, we're looking at diuretics that help to reduce fluid retention, and ascites, spironolactone, which decreases aldosterone levels, lactulose and neomycin, which decrease the nitrogen load in the liver and the ammonia level. Beta blockers, which help to prevent rebleeding and lower hepatic venous pressure. Antacids are given PRN, oxazepam, which is a benzodiazepine not metabolized by the liver, and that helps to treat acute agitation in this client. Nutritional support includes sodium restrictions, fluid restrictions, palatable diet that offers adequate calories and protein, and vitamin and mineral supplements. Lifespan consideration. Um, Pediatrics, one of the things is biliary atresia, one of the medical conditions, and the specific course of biliary atresia is not known. It is believed to be caused by the absence or blockage of the extrahepatic bile ducts. This results in blocked bile flow from the liver to the duodenum, causing inflammation and fibrotic changes in the liver. In addition to blockage, the disease can also be caused by hepatocellular dysfunction. The lack of bile acids also interferes with digestion, fat absorption, and fat-soluble vitamins such as A, D, E, and K, resulting in steatorrhea and nutritional deficiencies. Without treatment, disease is fatal. And so patients with biliary atresia need to have surgical intervention. And we've already talked about cirrhosis of the liver. Thyroid diseases. Again, I'm not going to read to you the objective slide, but it is as thyroid disease relates to metabolism. We are going to talk about hypo and hyperthyroidism. So hyperthyroidism, you have an excessive delivery of the thyroid hormone. They have so much thyroid hormone that everything is fast. They increase metabolism and protein synthesis. Affects all major systems. They get an increased metabolic rate, a heightened sympathetic nervous system response, cardiac output and blood flow increase. Lipids are depleted, protein deregulation increase, which results in a negative nitrogen balance. They have caloric and nutritional deficiency because their heart is racing so fast and their temperature is up. They end up with nutritional deficiencies. Etiologies include autoimmune simulation, such as in Graves' disease, excess secretion of THS or thyroid stimulating hormone, neoplasms or a goiter, and if they have too much thyroid medication. Risk factors and prevention, women get it more than men. There are genetic components of hyperthyroidism, increased iodine intake ages 20 to 40, and Graves' disease cannot be prevented, but one thing that we suggest is to stop smoking. There are multi-system effects of hyperthyroidism, and again, hyper, if you remember hyper, that means that your heart rate's going to be up, your blood pressure is going to be up, your baseline temperature is going to be up. You're probably going to have tremors because your nervous system is going to be hyper as well. You might get diarrhea, nausea, vomiting, hair loss, other problems like that. And so all related to the hyper effect of the release of the thyroid hormones. Graves' disease is an autoimmune disorder. It's the antibody that binds to the TSH receptors causes a hyperfunction of the thyroid cells. You'll get an enlarged thyroid gland, which you can see here in this picture. Let's see if I can draw for you. See the enlarged thyroid gland. Proptosis and exophthalmos, which when you see the bulging eyes is what that is. Fatigue, difficulty sleeping, hand tremors, change in menstruation. Older patients may develop atrial fibrillation, angina, and heart failure. Hyperthyroid disorders include toxic multinodular goiter, independently function nodules of the thyroid gland. Too much TSH stimulation equals or leads to an overproduction, often from a pituitary adenoma. Thyroiditis is inflammation due to viral infection, and thyroid storm or thyroid crisis. This is a rare extreme hyperthyroidism. Rapid increase in the metabolic rate. All of a sudden, their heart rate just jumps, their temperature just jumps, and is high, like 104 Fahrenheit, 105 Fahrenheit. Their heart rate is super fast, 140, 150. So they need to be treated right away, and they're treated symptomatically until we can get other things on board. But we want to cool them down, we want to replace their fluid, and stabilize their cardiac and respiratory systems. Collaboration, we want to prevent complications, and then we're going to be doing diagnostics such as T3, T4, and TSH. Treatment, antithyroid medications, beta blocker, such as propranolol, which decrease the cardiovascular effects. They may need some radioactive iodine. They may need a thyroidectomy surgical procedure. Lifespan concerns with hyperthyroidism include for children, it's similar to that of adults. For pregnant women, 1 in 500 pregnancies, they can develop Graves' disease and hyperemesis gravidarum. Untreated can lead to heart rate, preeclampsia, thyroid storm, miscarriage, premature birth, and low birth weight. Older adults, they can develop a toxic nodular goiter, often only 1 or 2 symptoms. They have other comorbidities, and so the symptoms might not be picked up on. Hypothyroidism means they don't have enough thyroid hormone. Pathophysiology is the decreased production of thyroid hormone. The thyroid gland enlarges. One of the diseases is called myxedema, and they get non-pitting edema in connective tissues. Etiology, its primary can be congenital defect, treatment of hyperthyroidism. So if they have their thyroid removed or partially removed, then they're taking away those thyroid hormones. Thyroiditis and iodine deficiency. Secondary is pituitary TSH deficiency. Amiodarone can cause that, which is a cardiac med that is caused because of the iodine relationship. And it most often hypothyroidism occurs in women between ages of 30 and 60. Risk factors and prevention: females usually older than 50 years old. I already said thyroid surgery, or if they have neck radiation. Etiologies include iodine deficiency, which could be caused by medication. They're listed here for you. And dietary concerns. That's one of the reasons that many, many decades ago, they iodized our salt to deal with iodine deficiencies and other issues related to that. Hashimoto thyroiditis is the most common cause of hypothyroidism in adults and children. It's an autoimmune disorder that destroys functional thyroid tissue, and they may require iodine supplements, especially in undeveloped countries. Clinical manifestations: slow onset for hypothyroidism, anywhere from months to years. They may have a goiter, they may get fluid retention and edema, decreased appetite and weight gain, constipation. So remember that with the hyperthyroidism, everything was sped up. With hypothyroidism, everything is kind of slowed down. So they get constipation. They may get short of breath. They'll may be pale, have some hoarseness and some muscle stiffness, especially if they've developed a goiter. That's where the hoarseness will come into play. They have a decreased sense of taste and smell, menstrual disorders, and can have cardiac enlargement. There are multi-system effects of that. I think I've talked about everything already. Lethargy is one of them. Slow speech pattern, periorbital edema maybe. I think everything else we've talked about. Brittle hair and nails is another classic sign. The hypothyroid patient, well, actually both patients with thyroid disorders, what you're going to see is they're not, when they come to be seen, they're not dressed for the environment. And so what I mean is the person with hypothyroidism is going to just be colder than normal. So they're going to come with a sweater on in the middle of July and maybe a scarf and maybe gloves on because they're that cold. Where the hyperthyroidism patient is going to like be in flip-flops and in shorts and a tank top in the middle of January when the rest of Florida has wearing their sweaters. Mixed edema coma is another concern. It's a life-threatening complication of untreated hypothyroidism. It's a metabolic disorder that includes hyponatremia, hypoglycemia, and lactic acidosis. Hypothermia is a concern. They get edema around their eyes, their hands, and their feet. Their cardiovascular system starts to collapse. They have impaired mentation and coma. It occurs in winter months for older women. Treatment is to address the precipitating factors, maintain patent airway, maintain fluid and electrolyte balance, maintain acid-base balance, maintain cardiovascular status, and increase the temperature. So you might have to put them with warm blankets or the bear hugger. Collaboration include diagnostics are the same, thyroid tests, pharmacology, we might replace the thyroid hormone, and surgery if the goiter impacts the airway. Lifespan consideration, infants and children may have a congenital hypothyroidism, and it is the most preventable cause of intellectual disability in infants and children. Pregnancy, so my slide isn't written correctly, but thyroid disease that occurs in pregnancy may be caused by Hashimoto disease, unlike how my sentence reads on the slide. Older adults may be due to thyroid atrophy, fibrosis during aging, and at risk for hypothyroidism.